therapies, and then the gut microbiome. Now, the problem in a stepwise approach, where most of the guidelines are telling us that go ahead and start with a metformin and thereafter go for the next drug when the A1C goes high, is we are tackling only one of these multiple defects, and that's at the level of the liver and the hepatic glucose output. And we are just keeping the rest of the pathophysiological defects to run amok, and that could be one of the reasons that in spite of the fact that we achieve some degree of glycemic control with this approach, we have not been able to take care of the complications, which comes up in a very silent manner, and by the time it presents itself, it becomes sometimes too late to aggressively treat such patients. So this is the VERIFY trial which was presented this time, which is the stepwise metformin followed by a second drug and then a third drug, or straight away start off with multiple drugs from day one. Here they used a gliptin and a metformin, but as I'll show you, there are other trials which have used multiple combination drugs. And the main target is to use the drug combinations to address the different pathophysiological defects which are already there. And the treatment which targets a pathophysiological abnormalities, the strategy is not about only that, only by reducing glucose or taking care of fasting or PP sugar A1C, but also correcting as many as of those pathophysiological pathways as possible. And that early intensification can, as a result, give us a more durable treatment because it can give rise to a lot of beta cell rest and preservation of C-peptide, because as we know, the exogenous insulin that we inject doesn't have a C-peptide. And there are a lot of hypotheses that the internal C-peptide gives a lot of protection, especially microvascular disease protection. So as much as of the beta cells we can preserve, we can actually take care of a lot of microvascular complications. So this is what was tested, and animation. Okay, I'm sorry, but there was animation here. But if you look at the early combination therapy, which is this VERIFY trial, or if you have the EDIT trial, which was done by Abdul Ghani Difronzo, very similar strategy was done here by Abdul Ghani and group, the Qatar study, where a large population of patients were from India. And here you find they use the incretin-based therapy, a pioglitazone, and the sulfonylurea and metformin. In the EDIT trial, they have used a pioglitazone, metformin, and incretin-based therapy. And the one which I've just showed you now, the VERIFY trial, used a combination of a gliptin, that is incretin-based therapy, and metformin. And all of them were superior in contrast to the stepwise management because as far as achieving the A1C is concerned and durability. Up to 4 years they have seen these trials, and they have found that using multiple drugs which do not cause hypoglycemia, even if you use them in combination, is superior, is durable, has lesser hypoglycemia and lesser glycemic variability. So the prevention of complication is the second step, or the second change which has come up. This is the AACE 2019 position statement, saying that you need to achieve the ABC, or they have now called it the ABMC, or ABBC, which is the HbA1c, the systolic blood pressure, BMI, and cholesterol. And we need to achieve all these targets without inducing hypoglycemia, weight gain, and also preventing both micro and macrovascular complications. So how do we prevent complications? Now, while initiating our anti-hyperglycemic agents, we need to put in drugs early on which can alter outcomes, and then we can complement with other agents. So a lot of people initially started saying maybe it's time to show sulfonylurea at the door, pioglitazone the door, there's no role of AGIs, etc. No, they do have their role, but maybe they do not have their role early on in the disease process. Maybe the time has come that we should not initiate our patients with a sulfonylurea metformin. Time has come to use a pathophysiological approach. A metformin pioglitazone is a very good thing to start or initiate with. A metformin gliptin is a good combination. A metformin SGLT2, a metformin GLP1, or maybe a combination of 3 of such drugs makes sense. And because these drugs are capable of taking care of complications, and then if our metabolic targets are not achieved, we can complement that with a sulfonylurea, with an AGI, with other drugs which are also there with us. So it's good to have a lot of drugs available with us. The only issue is how to place them, either in a hierarchy or in combination. And let's not forget the step 3, aggressive tackling of the other comorbid conditions. Systolic blood pressure reduction and bringing it to target, aggressive statin, not 5 milligrams of some statin, but good dose of 20 milligrams of atorvastatin, which is the baseline statin to be used according to the NICE guideline. There is no 5 or 10 milligrams of atorvastatin. So every patient should get a 20 milligrams of atorva or 10 milligrams of rosuvastatin. So if you use those and fortify lifestyle modifications, cut down on carbs, increase more protein, increase more fruits and vegetables in diet, and take care of your lifestyle when not inducing weight gain, we can make a huge change as far as the future complications are concerned. So this brings us to the second part, because most of the guidelines for the last 2 years have now classified positioning of drug based on a very basic question which is asked right at the outset when the patient is coming to a chamber. Do you have an established atherosclerotic cardiovascular disease or not? Because if you have, then the treatment strategy is different. If you don't, then the treatment strategy is different. So I'll go by one. Let's look at those who have an established atherosclerotic cardiovascular disease. Now, as I showed you, if we bring all the ABC under target, especially achieve our target HbA1c, there are only 4 parameters we can make an impact on. The one in these yellow boxes, we can prevent new onset progressive retinopathy, we can prevent new onset persistent macroalbuminuria, we can prevent non-fatal stroke, and we can reduce the future risk of all-cause mortality. These are the 4 things which can be impacted by achieving an HbA1c somewhere between 7 to 7.5. But then there's a whole gamut of complications which are left unattended even after achieving the HbA1c. And probably that's where we have gone wrong in using powerful glucose-lowering agents, achieving our targets, but have not been able to make an impact on the complications. So now we have agents which are capable of making a difference on the other complications like renal death, end-stage renal disease, progression to end-stage renal disease, progression of macroalbuminuria to end-stage renal disease by use of an SGLT2 inhibitors, and we have now primary outcomes data from the CREDENCE trial. We can make a difference in myocardial infarction and stroke rate reduction. We have seen from the GLP-1 receptor agonist data, especially liraglutide and semaglutide. Stroke reduction, although not a primary endpoint, but we do have some meta-analysis data that pioglitazone have a good impact in reducing strokes and TIA. We can also make a difference on cardiovascular death and heart failure, the composite reduction with the use of empagliflozin, dapagliflozin, and canagliflozin. So we can combine this, that is a good control of HbA1c, and utilizing drugs which can make an impact on multiple comorbid conditions. We can definitely take care of number of micro and macrovascular complications with such a strategy. This is the ESC guideline. Very recently, this was one which created a controversy. I do not know why it created a controversy, because they have assimilated all the evidences, and I think it's a perfect evidence-based algorithm which they've given us. So here you have type 2 diabetic patients who are drug naive, or you have type 2 diabetic patients who are already on a baseline metformin. Suppose they have an established atherosclerotic cardiovascular disease, or at a very high risk, which is defined both by the dapagliflozin DECLARE trial as more than 1 risk factor, or the CANVAS trial with canagliflozin as more than equal to 2 risk factors plus diabetes. For example, you have diabetes plus hypertension. They fall in the DECLARE TIMI 58 inclusion criteria group. You have type 2 diabetes with hypertension and dyslipidemia, so 2 risk factor, you fall in the CANVAS inclusion criteria. So anyone with established cardiovascular disease or type 2 diabetes and at least 1 or more risk factors, which can be hypertension, which can be dyslipidemia, which can be smoking, which can be a family history of premature cardiovascular death or family history of atherosclerotic cardiovascular disease. In these circumstances, SGLT2 or GLP-1 is the first-line drug. As a matter of fact, metformin has been displaced as a second-line drug or a third-line drug in this particular algorithm, and rightly so, because metformin doesn't have any hardcore data that it reduces any macrovascular complication. And the only trial which was being done, which is the GLINT trial, has been discontinued because of lack of funding. So we will probably never know whether metformin is safe from cardiovascular perspective or it reduces any atherosclerotic cardiovascular disease. Now, those who do not have atherosclerotic cardiovascular disease and those who do not have any of these additional CV risk factors, metformin and the cafeteria choice of any other drugs can be used. Here, the main differentiating factor is weight gain, the hypoglycemia and risk of hypoglycemia, and obviously cost, which becomes extremely important. But the issue is atherosclerotic cardiovascular disease and high-risk cardiovascular high-risk individuals can be classified into 2 groups. For example, if you have a high risk of MI stroke, or you have a high risk of heart failure and hospitalization for heart failure. So which one do I choose, an SGLT2 or GLP-1 in such a circumstance? And that is what is very important to understand, because these are based on the label change that these molecules have. Remember, your patients, when they go home with the drugs that you write, will always open up the boxes that they have and can read whatever is written there. So if I tell my patient that I've given you this particular drug, for example, a tenaligliptin, and I say that this is safe from cardiovascular perspective, it is not written in the package insert. The patient can go back and read that and find out the dichotomy between my statement and what exactly is written in the package insert. And a package insert is reflective of the evidence and what the regulatory authorities mandate the pharmaceutical company to write. So if you look here, from SGLT2, if I tell my patient, you already have an established atherosclerotic cardiovascular disease, or you have diabetes with certain CV risk factors, and I'm giving you a drug. Why? Because it's going to reduce your risk of CV events like MACE. Then this statement is true if I use an empagliflozin, canagliflozin, or dapagliflozin with a very strong class 1A indication. An appropriate statement, which is also reflected in the package insert that a patient goes and cross-checks at home. However, those who have an established cardiovascular disease are very much prone to have a sudden cardiac death or second event, which are usually fatal. So if I want to give a SGLT2 and which is going to reduce a cardiovascular death risk, then the drug of choice is empagliflozin, which has a 1B indication. So it depends what am I communicating to my patient. If I tell them, here you have an MI, you have come to me, and I want to give you an SGLT2 inhibitor to reduce CV events, if that is the statement, I can choose any one of these three. If my statement is this is going to reduce the risk of cardiovascular death in the future,